Thank you so much all for your patience. Planet is largest live digital CME doctors generated medical content platform. Our website is www.planet.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we have made wiki services, which is medical Wikipedia for doctors, only that also you can read in your leisure time. We will invite all the doctors to visit our website. Now, your further delay, I would like to hand over the session. Oh, and before hand over the session, I just like to introduce today's master doctors. Dr. Amit Kumar, consultant pediatric oncology. Dr. Shruti Bajaj, director and consultant clinical geneticist. And Dr. Rasmi Palassery, assistant professor. Okay, so Dr. Amit Kumar, hand over to you, sir. Please proceed
Uh,
with your talk.
Thank you,
Thank
Mamita,
you.
and thank you, Team Planet, for providing this stage for this CME. So, I welcome Dr. Shruti Bajaj first, who is a director and consultant clinical geneticist with the Purple Gene Clinic, Mumbai, and she will be talking on cancer predisposition syndromes. Welcome, Dr. Shruti.
Yeah. A very good evening, everyone. Again, I would like to thank Dr. Amit for the introduction as well as this platform. So today's topic is on childhood cancer predisposition syndromes. It's going to be a short discussion aimed in a very case-based manner, practical scenarios that we see in day-to-day life. In today's talk, we're going to try and understand these broad concepts, very, very basic. What are these cancer predisposition syndromes? Why should we suspect it? And, when should we suspect these cases early? And having done the why and the when, how should we broadly proceed with the test in such cases? So, without much delay, we'll start with the understanding, a background building of what are these cancer predisposition syndromes. So, as the name suggests, a genetic predisposition to develop certain tumors, which can be transmitted from one generation to the other, is broadly known as cancer predisposition syndrome. Now, we realize that these cancers can be either due to certain germline variants or due to somatic variants. Now, it is interesting to note that as per a recent publication, the proportion of the childhood cancers that are secondary to germline variants, that is inherited cancer syndromes, accounts for nearly 10% of all the childhood cancer that are seen. Of course, sporadic somatic mutations would still account for the larger 90%, but 1 in 10 still warrants attention to dwell further. And that's the reason why we are going to be taking this session ahead. Of course, as per some other articles where they used deeper sequencing platforms, this yield even went up to 15% of all the childhood cancers. I'm going to take you all through a very practical case, and I think we'll understand why and how cancer predisposition syndrome is actually a end result of multidisciplinary care. So this was a 8-year-old male child who presented with a mass on the right lateral border of the tongue. You can see it was a lobulated surface. There were no external bleeds. This child had presented to the pediatric surgeon with a biopsy elsewhere, which read that it was a mucosal neuroma. Now, the pediatric surgeon, wondered, because the moment we listen to mucosal neuroma, you are wondering whether this is only mucosal neuroma or is it a part of a syndrome complex, what we call as MEN2B, where we see mucosal neuromas, marfanoid body habitus, medullary thyroid carcinoma, pheochromocytoma. And it was with this background that, the although he looked at the rest of the features of meant to be were not there. But there was a thought process for the pediatric surgeon that see if this is a meant to be syndrome, it is a serious diagnosis. And I may not need to just excise the tongue mass, but even do other prophylactic surgeries. Like we know that meant to be is associated with very fulminant thyroid cancer, and it warrants prophylactic thyroidectomy. So with this background, the surgeon had actually even done a hereditary cancer panel, and that had turned out to be inconclusive. And that's when the patient actually was presented to the geneticist to know what's really happening. And as it often happens, the more we progress in science, the more basics become important. So we started with a very simple pedigree elicitation, family tree elicitation. This is, I would say, the poor geneticist's first genetic test. And you can see that initially on the history, it looked to be very clean. But when we went deeper, the mother said, yeah, you know, my mother had some cancer, I'm not very sure, some abdominal cancer. And we know often that these are secondary mets, liver mets causing ascites and all, and it's often just termed as abdominal cancer. And we dug some bit deeper and we examined the child. He had some non-specific dysmorphism. But the penny actually dropped when we saw these large capiolae macules in the child as well as the mother. And now the pedigree changes. This is a child who's got a tongue mass, and there are capiolae macules in him and the mother, CALM, and there is a cancer in the grandmother. And we were thinking aloud, can this be some autosomal dominant condition which is coming from one generation to the other, and which has got variable presentations, including some masses, some cancers, some capiolaes? And I'm sure many of us in the audience would be also thinking, can this be neurofibromatosis? But the challenge was that this patient had come with a clear-cut biopsy report of mucosal neuroma. And when we read further, actually, it was very interesting to note that the plexiform neurofibromas can actually have a biopsy picture which mimics mucosal neuroma. And our suspicion of neurofibromatosis could have been correct, because we know that neurofibromatosis is associated with an increased risk of breast cancers. When we dug further, the mother did say, yes, my mom had some few innocent nodules, but not too much. She had these capiolaes too. And when we took a biopsy again, it was indeed a schwannoma, which was mimicking the, a plexiform neurofibroma, on biopsy, which was mimicking or falsely labeled as a mucosal neuroma elsewhere. And then we did the eye checkup. There were leash nodules. The 24-hour catecholamine for pheochromocytoma, if it was to be meant to be, was normal. And now we reanalyzed the old genetic data with these new handles, this new phenotype. And what do we get? This was actually a case of neurofibromatosis, inherited from the mother, clear-cut pathogenic. And imagine, this test was already done. And this is a scenario nowadays where referral to genetics or genetic involvement is often an afterthought. You know, let's order the test, we'll see what comes in the report. But this is a perfect example of how the phenotype dictates the genotype. And this is not just, in our findings, there are studies which show that as the phenotypic yield increases, the genetic yield also increases. It was really rewarding for the family to get this decision, because you can imagine NF is not as serious oncogenetic condition as meant to be. It in fact doesn't have all those serious cancers associated, surgical decisions for the child, oncosurveillance for the mother because she's at a risk of breast cancer, testing for this mother's asymptomatic siblings. And of course, nowadays there is an FDA-approved drug for neurofibromatosis in the form of selumetinib for the inoperable serious plexiform neurofibroma. So you can see how there was a 360-degree turn based in the approach, based in the prognosis, based in the surgery, based on the prognosis, by merely simple history taking, phenotypic elicitation, and revisiting the lab. This is what I was telling, where they had found that as the number of the phenotypic terms increased, phenotype is the clinical information that we provide to the lab. So if for the same patient, same lab, this was a huge meta-analysis studies, which showed that as the phenotype, number of phenotypic terms increased, the yield also increased. And it's not a surprise. Often we see in clinical medicine that the output, in fact, depends on the clinical input that is provided by a lot of the diagnostic tools. And it's just a gentle reminder to all of us who feel that in an age of artificial intelligence, clinical skill and the human component can get replaced. I feel in the era of next generation sequencing, we still need our generation clinicians. We still need next generation phenotyping, next generation clinical skills. With this little piece build up, I'm going to touch upon how does one work up, when you are suspecting a cancer predisposition syndrome. So if we take this grammatical sentence, give me the book, and if I was to delete or duplicate this entire sentence as it is in the first row, this is a large deletion or a duplication. And it is, for an example, what you want to see, say monosomy 7. You want to see that the entire chromosome, whether is deleted, duplicated. You need a test like karyotype. And this is a copy number variant. Now, if there is a micro deletion, I have just deleted or duplicated a part of the sentence. At such time, a karyotype will not suffice. I need a more finer tool with a more resolution. And that is provided in the form of microarrays and MLPAs. Then you have this last panel where there is no micro deletion, no micro duplication. Rather, the letter K has got replaced with T. And this is not a copy number change. Rather, it is a single nucleotide variation where, because of the change in the spelling, the single letter, the entire meaning has changed. So example of micro deletion, micro duplication, we know there are sometimes del loops in the BRCA gene, or for example, DiGeorge-Williams syndrome, the WT1 deletion in Wagger. These are all micro deletions, micro duplications. And of course, in the single nucleotide variants, all those single mutations, for example, sickle cell anemia, thalassemia, retinoblastoma, majority of them, these are the ones that are single nucleotide variants for which you need next generation sequencing. One amongst the common tests over here is the exome sequencing. So we need to understand that there are different levels of test for different levels of errors. Many cancer predisposition syndromes can be now diagnosed by these NGS platforms. However, there is a word of caution that that is not the be-all and end-all. You saw in the first case how the test ordered was correct, but because of the adequate clinical information, the ordering physician could not arrive at a result. Within the NGS platforms, you have whole genomes, which are not really easily applied in clinical medicine. It's usually the exomes, and if it is a part of the exomes, the panels, which are common and popular within the oncogenetic domain. As I would say that we need to remember that not all these syndromes can get picked up by, exome sequencing. I've given examples of how for Beckwith-Weidman syndrome, you need a test called as MLPA. How for 10 to 15% of the BRCA-related breast cancer, I know this is a childhood cancer predisposition syndrome, but it's just to help us understand the common cancer genetics and their applications. Of course, with the newer genes being discovered, people are gradually moving from narrow panels to exomes and genomes. But as I said, the answer over here is not always ordering a larger test, but ordering the test with the right number of and the proper clinical information. We need to understand that when we do these tests, There are many vectors that are taken into consideration, and through a blend of artificial intelligence, computational tools, bioinformaticians, human inputs, finally these variants are classified into one of these five major categories: either benign or likely benign, which means they're unlikely to cause the disease. Uncertain variants could be uncertain, they could be true positive or false positive, and again, likely pathogenic or clearly pathogenic. We need to understand that uncertain variants need to be taken with a pinch of salt. A large share of them, when followed up prospectively, actually get downgraded to being benign. So in a domain like oncology, where you really are sometimes pushed to take major decisions based on your genetic results, we need to understand that we should not be basing our clinical decision and prenatal decisions on these uncertain variants. Uncertain variants should be ideally, there should be efforts made to segregate them clinically through biochemical analysis, parental testing, reverse phenotyping. But despite best efforts from your genetic colleagues, if the uncertain variant still remains uncertain, one, you need to wait and watch and see how it evolves with time. This is just about another case vignette. This was another child, 2 years 9 months. She had bilateral retinoblastoma, was operated and given chemotherapy. And we are aware that retinoblastoma follows the Knutson's two-hit hypothesis, where in the hereditary types, especially the ones that are the bilateral ones, one of the mutation is inherited and the second hit is an acquired one, thus triggering into tumorigenesis. Whereas in the sporadically occurring retinoblastoma, it is a single hit which is an acquired mutation. Now, we need to understand that in the hereditary retinoblastoma, since one of these mutations is inherited, it means it is a germline mutation. Germline means it is since the time the conceptus is formed in the mother's womb. And thus, each and every cell should carry this mutation. And so, when checked in the blood, these germline tumors do yield genetic results. We do not have to rely on the tumor tissue for that. So it is a blood test, which is done for these oncogenetic tests. Now, we know that bilateral retinoblastoma is nearly always, 85% of them are, 85% of the hereditary retinoblastoma are bilateral, and nearly all the bilateral RBs have to be suspected to be due to an inherited variant. So in such a case, it seems to be pretty straightforward, right? I mean, it's bilateral. Let's just order the genetic test and let's order the NGS platform. Well, the test ordered may have seemed to be correct. However, it was a bit of a surprise to the oncosurgeon that the report came back as no variant detected. And that is when the patient again met the geneticist. They came and when I saw the family, we realized that we need to understand that in retinoblastoma, if it is only retinoblastoma, isolated bilateral retinoblastoma, yes, NGS-based test and exomes are the test of choice. But if this is a group of players, if it is a syndromic retinoblastoma, where there are other clinical features associated, then you need to do the microarray in that case, which is another test platform. When we saw this child, what do we notice? She had prominent hypotonia, delayed speech. Often we tend to attribute the delayed milestones or the child is visually impaired. But if she is listening properly, her hearing was normal, there's no reason why the speech should be delayed. And the global delay was not commensurate to just the vision loss. So we concluded that this was a syndromic retinoblastoma, ordered the microarray. And lo and behold, this was a case of 13q14 deletion, where a large segment of the chromosome had got deleted. Within this deleted segment was the RB gene, thus causing retinoblastoma. But there were 220 other genes that were also deleted. thus explaining the rest of the spectrum in this child. So you can imagine now, again, it's important to give this diagnosis because for the proband, we know that the heritable retinoblastomas are at risk of other primary tumors. There are other genes that are deleted now that we would have to keep a watch on. Has this deletion got inherited or has it occurred on its own? Are the siblings at risk? Is the next child at risk? Many questions open up the moment we have a confirmed diagnosis. Coming to the last segment of the talk, why should we suspect these cancer predisposing syndromes early? Well, yet another case scenario. I'll run through it very quickly. This was a female with chronic cytopenias, frequent and prolonged fevers. She had short stature, failure to thrive, microcephaly, cognition was normal, delayed speech, oral ulcers, hypopigmented macules. You can see these, and caffeole macules too, along with a lot of freckling around the neck. So, for those who are used to seeing these syndromes in clinical practice, it was like a spotter. This was, in fact, although the child hadn't developed a cancer, she actually was referred to us through pediatric services. But I suspected the Fanconi spectrum or like a DNA breakage spectrum based on these features. Of course, and so we did the stress cytogenetics and also the genetics using the exome sequencing, and that indeed showed compound heterozygous FANC D2 variants. Both the parents were carriers. It was a high evidence variant, likely pathogenic, and so this was Fanconi anemia type 2. And you can understand why this was important because we kind of realized that this is not just related to Fanconi anemia. There's so much more to it. There is that in Fanconi anemia, the child can have unilateral renal agenesis, moderate hearing loss. It's associated with leukemias, hypothyroidism. Of course, even when we start, if the child develops cancers and if these children are put on chemotherapy, they are at higher risk of drug toxicities, chemotoxicities. And it is all this prognostication, surveillance, which can now be offered to the family because we have a diagnosis. And this was their first child. Needless to say that this is an autosomal recessive condition. There's a 25% risk of recurrence. We had diagnosed the accurate mutation, not just a clinical diagnosis. And so now we were in a situation to offer the family prenatal counseling in the next pregnancy. So the impact of an early diagnosis is to offer precise personalized care. We know that based on the mutation, there are times when the treatment protocols change, the choice of the drugs will change. And really, it's a very brainstorming and exciting collaboration between genetics, oncology, oncosurgery. And it's really exciting times to be into help to be able to give the patient such comprehensive answers. Of course, it helps us to plan the surveillance, genetic counseling, as I said, to the as yet unaffected family members. And not to forget the last aspect in today's practice where a delayed suspicion could mean a delayed diagnosis. And we really don't wish to logically, upset patient journeys, cause more delays. In a recent ENT survey, failure of duty to refer to the appropriate specialist was the second most common cause of medico-legal litigation. And that's the reason why when we suspect a cancer predisposition, we need to refer early. What are these red flags? Well, there was a very interesting paper by Rippeger et al. In 2017, where they argue...
Sorry, Dr. Shruti, can you finish early? We are running short of time.
Yeah, so I will just push this off that these are the red flags in the presence of family history, cancer types or cancer features known to be associated with CPS, patient with 2 or more malignancies, child with cancer with congenital and other anomalies, child who suffers excessive toxicity on cancer therapy. These are the red flags to suspect cancer genetics early. And these are my messages which I have already highlighted on. Thank you so much for your patient time listening. Thank you.
You finished really early.
I was about to finish actually, but then since you said, I was like, yeah, fine.
Thank you, Dr. Shruti. From onwards, we have become a bit more vigilant, and we'd like to refer to a geneticist. So maybe it will be of help to all of us and for the patients also. So our next Palassery, who is assistant professor in pediatric hematology oncology at Ramaiah Medical College, Bengaluru. And she will be,
Sorry to interrupt, sir. Your voice is breaking.
am I clear right now? Am I
You are.
audible?
Yes, sir.
Yeah.
You are.
So the next talk, so we will take the questions in the last of the session. So next talk is by Dr. Rasmi Palassery, who is assistant professor in pediatric hematology oncology at Ramaiah Medical College, Bengaluru. And she will be talking on screening and intervention in a case of pediatric oncology study syndromes. So welcome, Dr. Rasmi, and the stage all yours.
Thank you so much. Pleasure being here. I'm just going to share my screen and see if everybody can view it. Is the screen being projected okay?
Yeah.
Thank you so much. So good evening, everybody. I will be sharing a 20-minute talk, basically on the screening of children with cancer predisposition syndrome from more of a clinical perspective as to whom to screen, how to screen, benefits and sort of pros and cons of screening. So the genetic alterations that predisposes one to developing cancer can be classified as mutations of tumor suppressor genes. Classic one is our RB gene mutation. Mutations of oncogenes. Example is the RET gene mutations that you see in MEN2 syndromes. And then mutations of DNA stability repair genes. Examples, Fanconi's, ataxia, telangiectasia. There are of course genetic alterations that don't come under these three as well, but this is just a broad attempt to segregate things. So whom to screen? Understanding of cancer predisposition syndromes is not something new. We've known about it since Lifromini syndrome was described in the 1960s, and since then the idea or the criteria that a child or an adult has to meet to get screened for an inherited cancer predisposition syndrome has not changed much. One, the foremost one is the family history of same or related cancers, multiple cancers, bilateral, multifocal or multiple cancers, age at diagnosis. For example, a 15-year-old or a 16-year-old getting a CA breast, or an 11 or 12-year-old getting a CA colon. Physical findings suggestive of predisposition syndrome. Dr. Shruti had shown a few pictorial slides earlier where you can see physical evidence of syndromes like Becker-Wiedemann or Fanconi, and even before the actual cancer develops, and occurrence of certain specific tumor types that are classically associated with certain genetic syndromes. For example, when you talk about family history, what we are actually talking about is a certain classic pattern of occurrence. That is either 3 generations affected by cancer, obviously on the same side of the family, maternal or paternal, 3 or more family members with the same type of cancer, or a first degree relative with cancer, 1 or more than 1. Then coming to the specific tumor types, I briefly mentioned this earlier, certain types of cancers that are typically seen in an older age happening in a younger child, or a constellation of tumors. Of course, everybody knows about BRCA these days because of the association of certain celebrities with this particular syndrome. So occurrence of breast and ovarian cancer, occurrence of colon and uterine cancer together. Now, coming to the physical findings part, so there are a large set of symptoms that typically raises the suspicion for an inherited cancer predisposition syndrome. Phenotypically, short stature, thumb, limb anomalies, spine anomalies, macrocephaly, microcephaly, certain skin features like telangiectasia, scaphoid spots, hyperpigmentation, hypopigmentation, and each of these symptom arrays have a constellation of tumor syndromes that are associated with them. For example, everybody knows that thumb radius anomalies are classically associated with Fanconi anemia, whereas telangiectasias are more suggestive of ataxia-telangiectasia, caffeolate spots, neurofibromatosis or Fanconi, short stature, again, Fanconi. So now, just to kind of typically go through some of the common tumors associated with cancer predisposition syndromes, we'll first talk about solid tumors. So especially in the pediatric world, the first thing that comes to mind is obviously, Wilms tumor and the associated syndromes. So there are the overgrowth syndromes like Beckwith-Wiedemann, hemihypertrophy, and then there are specific ones like Wager, Dennis-Grash that are associated with Wilms tumor. Another one to not forget is the hereditary retinoblastoma, syndrome in children with either unilateral or bilateral retinoblastoma. Then hepatoblastoma, again seen with Beckwith-Wiedemann, and even with familial adenomatous polyposis. This is something of importance because they will get hepatoblastoma at a younger age and other colonic tumors at a later age. Then the tumors associated with neurofibromatosis 1 and 2. Neurofibromatosis 1 is more sarcomas, neuroblastomas, whereas with NF2 it is more CNS nerve, like nerve sheath tumors, meningiomas, schwannomas. Now, this is for the solid tumors. When it comes to hematolymphoid malignancies, the classic cancer predisposition syndromes associated with ALL are P53 mutations, and certain marrow-based disorders like DBA, Schwachman-Diamond, certain mutations of genes that are associated with the genetic profile of an ALL, like ET56, PAX5, SH2B3. AML has a lot more syndromes associated with its occurrence in a familial pattern. Fanconi, DBA, SDS, DKC, diskeratosis congenita, all basically DNA repair defects, and even mismatch repair deficiencies. Lymphomas. Now, lymphomas are another interesting group, and specifically talking about non-Hodgkin's lymphomas, not Hodgkin's. So non-Hodgkin's lymphomas, where you can have a B cell or a T cell phenotype, are usually seen as a part of disorders where there is an inherent lymphocyte defect. Example is your X-linked lymphoproliferative disorder, which is a type of immunodeficiency. Another example is X-linked A-gamma globulinemia. There are a varieties of mutations, some well described, some not so well described, that predisposes you to developing common variable immunodeficiency. All these three immunodeficiency group of disorders predisposes the patient to developing non-Hodgkin's lymphomas, either B or T type, later in the life. To sort of discuss the syndromes that are associated with cancer predisposition, this is basically from the AACR 2016 statement paper, where they classified the syndromes into sort of 9 subheadings. The Li-Fraumeni group of disorders, which is either P53 or associated mutations, neurofibromatosis, which is NF1, NF2, overgrowth syndromes and Wilms tumor, neural tumors, this is more of paragangliomas, schwannomas, GI cancer predisposition syndromes, again Li-Fraumeni along with FAP, HNPCC, neuroendocrine syndromes, very well described, MEN1, MEN2, leukemia predisposition syndromes. I briefly mentioned this when we talked about ALL and AML causing CPCs. DNA instability disorders, a lot of them present as bone marrow failure syndromes and cytopenias early on. And then miscellaneous that is not grouped under the above 8, but still are classically described CPCs. So how do you actually design a screening test for these cancer predisposition syndromes? Because there is no one unifying factor. It's not like they all affect one particular organ or they all have one set of clinical manifestations. So there are sort of 3 points to sort of concentrate on when you think about screening for a cancer predisposition syndrome. One is that the screening should be justified ethically, financially, clinically. So there should be a positive risk-benefit ratio. That means there is at least a 5% or greater risk of developing cancer during the first 20 years of life. Effective screening modalities should be there. And the prevalence of that particular mutation associated malignancy in the population should be at least more than 5%. The second comes to, is there an advantage to initiating a screening test for the CPS? So there should be a possibility of early detection of cancer. where you can attain less organ toxic and less intensive therapy because you are detecting at an early stage with better outcomes. You should be able to identify recurrence of the tumor, and you should be able to identify newer neoplasms that are associated with the syndrome. Then other point to be conscious about while designing a screening test is that there are certain side effects, physical as well as emotional, when it comes to subjecting a person through an array of screening tests. Especially a lot of the screening tests do involve some sort of imaging modality, because of which there is an exposure to radiation, contrast, other metallic safety issues that happens with MR. And most of these patients, when they require MRI and all that, they need some amount of sedation. So recurrent sedation, anesthesia risk. And of course, now the major part is the emotional stress that can happen because of false positive results, the harmful interventions that may be undertaken because of a false positive result. And after being identified with the CPS, once the understanding of the genetics come in, there is always that guilt of disease transmission that happens in parents. Typically, you get into the situation when we have these autosomal recessive disorders, because each copy of the defective gene came from one of the parents, and they sort of feel responsible for what has happened to the child. So there is no one good screening tool that is universally applied for cancer predisposition syndrome, but I just wanted to discuss this particular one. They call it a tumor predisposition syndrome in childhood cancer patients, TUPS checklist. Basically, it had a history sheet. It had a series of photos, and these were then evaluated by a clinical geneticist who recommends further screening and testing. So these are basically the sheets, the checklist that goes through. First is discussing the patient characteristics, the type of the disease, the age, stage. Then the family history, which is very detailed as to what kind of disease, cancers are there in the family, the inheritance pattern and all that. And then there is the physical examination of the patient, basically to look for the physical stigmata of CPS. And then finally, there is a decision support schema that talks about which tumors to be included and not included, what kind of history is significant, what kind of family history and what kind of physical examination findings are significant. So based on this, surveillance protocols have been developed for various syndromes, but only for a limited number of conditions for which preventative measures are known to exist. So under this comes a lot of the syndromes that we already know of, the inherited breast and ovarian cancer, BRCA group of disorders, Li-Fraumeni, Wilms tumor-associated mutations, FAP, juvenile polyposis, hereditary retinoblastoma syndrome. So I thought we will briefly go through one or two surveillance protocols in detail, and then sort of go into how to assess the advantage and disadvantage of the surveillance protocol. So the first one that I would want to talk about is Li-Fraumeni syndrome, because this is one of the first described tumor predisposition syndrome as early as in the 1960s. The Li-Fraumeni diagnostic criteria is that old, where the proband has to have a sarcoma at an age less than 45, a first degree relative who has a cancer at less than 45 age, and first and second degree relatives with cancer less than 45 years old or developed sarcoma regardless of the age. But this is sort of like a very stiff criteria, and what people found out was both ways. Like people had P53 mutations but didn't meet the criteria, or people had the criteria and didn't actually have a pathogenic P53 variant but some other gene upstream or downstream. So they are still classified as Li-Fraumeni or Li-Fraumeni-like syndromes, LF, LS. And there are again this Birch diagnostic criteria, LS diagnostic criteria to diagnose that set of patients. Now, whom to screen for germline TP53 mutation? It's based on what we call as the Chompret criteria, which incorporates the diagnostic criteria for Li-Fraumeni. And there are certain points to be met in the family history, in the personal history of multiple cancers, occurrence of certain rare cancers, including juvenile breast cancer. So once you meet this criteria, then you are referred to germline P53 screening. Now, once you find out that once you find out that you have a germline P53 mutation, then you start getting the screening process. Now, how advantageous is the screening process? So there are, studies that have looked into seeing what is the increased risk of the core cancers of leaf from any in a patient with p53 mutation as opposed to the general public. And you can see here that the core cancers, breast, sarcomas, brain tumors, adenocortical carcinomas, sometimes leukemias are also included in this. The incidence rate as well as the relative risk of developing is quite high in the affected population compared to the general public. So definitely there is an advantage in terms of screening these patients for these cancers. One of the first screening or more, comprehensive protocol that was developed was by the Hospital for Sick Children from Toronto group, David Malkin. So basically what they did was they prospectively observed family members of eight members of 8 families with leaf from any. They identified carriers and surveillance was voluntary. So basically they had 2 cohorts, some who underwent surveillance and some who didn't undergo surveillance. And what they found out was the overall survival, again, it's a short overall survival, it's a 3-year overall survival, was 100% in the surveillance group and quite less, 21% in the non-surveillance group. It is not that cancers didn't develop in the surveillance group, it did. But because of the surveillance, they were picked up at an early stage or at a stage where the treatment was still curative. So basically coming to the surveillance strategy, this is the original Toronto protocol. There are various other, the Japanese group has a similar protocol. MD Anderson has their own screening protocol. So they're all sort of using the same backbone, looking at the core cancers. Core cancers are adenocortical carcinomas, brain tumors, sarcomas, leukemias and lymphomas, and breast cancers. So screening for adenocortical tumors is using tumor markers like ESR, LDH every 4 months, urinalysis, ultrasound every 3 to 4 months. But for brain tumors, it's an annual MRI. For sarcomas, it's an annual whole body MRI. For leukemias and lymphomas, it is a CBC every 3 to 4 months, along with the other blood workup for tumor markers. So this is a strategy that is recommended until they are 18 years and younger. Once they cross 18 years and the risk of adult type of cancer, specifically breast and colon, as well as melanomas start happening. So this is the point where the breast examinations start and colonoscopies. Colonoscopies actually don't start up until the 4th decade of life or earlier if there is a proband in the family who has had earlier colon cancers. And the sarcoma screening and the brain tumor screening is just like as it is in the child, where it is an annual MRI of the brain plus an annual whole body MRI. So once you do surveillance like this, what is the advantage or is there an advantage? So different groups like Toronto has their own surveillance protocol, so does Bethesda, MD Anderson also has, Dana-Farber has. So all of them have sort of gone back and analyzed their data to see how good are their screening tools. So some groups use only imaging as screening tools, whereas some groups like Toronto uses a combination of blood work as well as imaging. And all the detection protocols did show that there was a positivity rate of early identification of malignancies. There was a cancer detection rate was actually higher compared to non-mutated patients. And what they also found out was the combined protocols, that is the ones where imaging was combined with blood workup, had a higher disease capture rate or early detection rate compared to only imaging. So now we know that there is definitely an advantage of implementing this protocol in patients with leishmania. However, we also have to keep in mind that when the battery of tests becomes large, the number of false positives also increases, thus resulting in a increased unnecessary interventions and the anxiety part that's associated with it. So so this was leishmania. Just going back to some other more common CPSS and their screening modality. Wilms tumor predisposing syndromes like Beckwith-Wiedemann. So they start off with an abdominal ultrasound. That is a non-radiation exposure imaging tool. Continue imaging up until the age of 7 years, because after that the risk for Wilms tumor is less. For hepatoblastomas, they recommend screening with the serum AFP, and abdominal ultrasound is also a surrogate. And parents are usually taught to perform abdominal examination, and the child sees a physician every 6 months for the same. Similarly, for men 1 and men 2, because they are neuroendocrine tumors, this involves a lot of investigations to look for specific tumor markers. combined with some amount of imaging. For familial adenomatous, for FAP, there is hepatoblastoma screening at a younger age. And then starting at the age of 10 years, there is colon and gastrointestinal cancer. We have actually a 18, 19-year-old boy with FAP who actually had, colonic polyps developing from the age of 12 onwards, but just never sort of came into proper medical care because, they go from one person to the other thinking that, if they change the doctors, the polyps don't come back. And now actually, unfortunately, has, badly metastatic colon cancer. Another group of tumors that requires a screening from a younger age is neurofibromatosis type 1, because from an early childhood they need eye examination to look for optic gliomas. Similarly, there are other tumors associated with it, that requires CBCs and as well as annual physical examination. Some other tumors that are associated with blood-related malignancies like Fanconi anemia, the recommendation is to do a CBC every 6 months. Some protocols say every 3 to 4 months. Now, Fanconi anemia is actually an interesting disorder, CPS, because the spectrum of malignancies changes. It's very varied and changes over an age and based on certain interventions. For example, in Fanconi anemia, in the younger age group, you're more worried about bone marrow failure, ALL, AML, and as they age, the concern is more towards oral upper esophageal tumors. So they are recommended to undergo every 6 months evaluation with a dentist and even a nasolaryngoscopy every 6 months by the time they are 10 years and older. Now, the surveillance for upper esophagus, nasopharyngeal cancers, and oral cancers starts at an earlier age if the child undergoes a bone marrow transplant for a bone marrow failure. This is important because Fanconi anemia patients already have a higher risk of DNA breakage repair, which is compounded by the fact that they receive chemotherapy as a part of conditioning for a bone marrow transplant. However, when they go into like profound bone marrow failure, aplastic anemia, or a malignancy, a transplant cannot be avoided. So the screening protocol gets tweaked based on the clinical course of the patient. Familial retinoblastoma is an important disorder to talk about in our setup because we do see a lot of retinoblastomas in India. Apart from what is mentioned here, the protocol that we follow at our institution is a little bit more rigorous. Then the BRCA mutation and the surveillance is pretty much talked about all the time. So this is basically what we would like to follow for a patient with a mutated RB1 gene, which is examination under anesthesia very closely in the first 4 years of life, followed by annual ophthalmoscopic examinations up until the age of 7. Some protocols actually recommend even after the age of 7 up until the age of 12 to continue eye examinations at least annually. Now, another inherited tumor predisposition syndrome in childhood is inherited neuroblastomas, which can be due to either a ALK mutation or germline ALK mutation or a FOX2B mutation, and rarely even as a part of leaf from any. So in which cases, a combination of imaging, ultrasound, as well as tumor markers, which is urine VMA, HVA, is done every 3 months, closely up until the age of 6, then a little bit more spaced up and stopped after the age of 10 years because the neuroblastoma predisposition sort of weans off by that age. Now, the whole idea of screening is that, yeah, tell me.
Dr. Rasmi, you're studying short of time. Can you just wrap up?
Sure. Okay. So the next couple of slides are basically was a simulated study to see if cancer predisposition syndrome, the genetic screening, whether it should be a part of newborn screening. This was done in US, where newborn screening is a part of the federal healthcare. So what they found out was this again. This is a simulation. This was not actually done, but using data sets of how many children will be screened, what is the incidence of these disorders. What they found out that if you start screening for basic 11 mutations, there is definitely advantage, relative reduction in terms of mortality by as high as 50%, reduction in terms of incidence by as high as 46.5%, and survival advantage for adults even into their 4th and 5th decade of life, close to 15 to 20% by implementing newborn screening. This is yet this is yet again a virtual discussion and not actually implemented, but probably something worth discussing about. Now coming to the last few slides. So as we concentrate more on improving our techniques for clinical as well as genetic screening for CPSS, there are certain dilemmas to be discussed, specifically when it comes to the ethical issues in terms of withholding the sharing of information, prejudice and discrimination based on the disease, the safety, the ethics of the safety in terms of the interventions that are following the screening, and health policy recommendations about translating these to like a population-based screening. So I'll stop my presentation with the following key points. There is a growing number of hereditary cancer syndromes that are being discovered as the days go by. Identification of these syndromes can substantially influence the choice of screening and management options for the child as well as the family members. Genetic risk assessment, counseling, and testing are critical elements in the care of children with CPS. And again, there's really to think about the future direction of total genomic, like whole genome sequencing on a more population-based level, and the ethical aspects of it. Thank you so much. I hope I didn't exceed the time by too much.
Not much. Thank you, Dr. Shalini. Dr. Rashmi. Am I audible?
Yeah, you are.
Yeah, thank you, Dr. Rashmi. It was such an elaborate discussion on this CPS. So it was really nice to see such guidelines. So now we'll go to few cases that we commonly see in our practice, and we'll have a panel discussion with you, Dr. Monica and Dr. Shruti. And since Dr. Salini is here, I would like to include her in this too. Welcome, ma'am.
Hi, sure.
Yeah, ma'am. So we'll just discuss a few cases. So I'm sharing my slide. So going to first case, this was a 4-month-old female child, second born of non-consanguineous marriage. She presented with complaint of bilateral leukocoria and converging strabismus noticed by pediatrician on a regular checkup, and with unremarkable antenatal and medical history. So obscured by tumors. It was group EI and group EY.
Excuse me, doctor, you're not audible clearly. Is it just from my end, or even the others cannot hear you?
No, yeah, I think even I got, I also couldn't hear in the middle.
Okay, so am I audible? I'll just slow a bit. Am I audible?
Now you are.
Yeah, so UA of right eye, the optic disc was partially visible, and the 3 large foci of retinoblastoma were noticed adjecting in the vitreous cavity with satellite retinal detachment, and the macula was obscured by the tumor. It was group DI. Left eye UA, there was 3 multifocal yellow-white retinal masses with a feeding retinal artery and draining vein, a total retinal detachment, and secondary glaucoma. So it is group EI. The EHB scan revealed a endophytic mass in the right eye without posterior shadowing and a complete tumor invasion of the vitreous cavity with masking of the optic nerve in the left eye. MRI brain on orbit showed intraocular tumors, bilateral excluded neoplastic infiltrations, bilateral and excluded infiltration of the choroid and optic nerve. So in the family history, when we visited, mother had thiatrical left eye and says that she had no vision in the affected eye since early childhood. The other sibling was a 2-year female child, never evaluated but normal vision according to the mother. So first question, Dr. Rashmi. So how do we proceed with this further management for this child?
So this child actually has pretty advanced tumors in both eyes, group D and group E. So the first thing I would discuss with the ophthalmologist is in terms of a possibility was for any kind of salvage in at least one eye for the vision part. Which can be, in which case, a neoadjuvant chemotherapy or even a directed chemotherapy retinal artery infusions can be considered. And in the group E, obviously, we'll have to, follow with an enucleation.
Okay.
Yeah.
Yeah. So Coming to Dr. Shruti Bajaj. So, what is the role of genetic counseling and testing in such cases, and how do you test for the mutation?
Yeah. So as we discussed it in, I think, in my slides, I had put a case of retinoblastoma.
Yeah.
Bilateral retinoblastoma, highly likely to be genetic. If there are no other syndromic handles, if it is a pure and an isolated bilateral retinoblastoma, then RB gene sequencing that would be the test of choice. And there are times when around 5 to 6% of these cases, even though they are bilateral, do not get the mutations on the gene sequencing. And that's when you need other platforms like MLPA, which pick up deletions, duplication, and rarely test like microarray, which I showed in my case scenario. But broadly, as the oncologist, there should be assurance that it is only a pure RB and not a syndromic RB, Dr. Amit. Yeah.
Okay, so what is difference like in samples, like when you get the globe and the blood? So what will the difference if you get positive reports in both of them, like in one of them or both of them?
Correct. So see, the somatic mutation, the globe tumor tissue will have the mutation in the sporadic type as well as in the inherited type. I will just maybe, if I'm allowed, I will in 1 minute, what I told, there are two types of mutations. The sporadic one occurs after the embryo is formed. So each and every cell line will not have the mutation. Only the tissue which has developed the tumor will get the mutation. But so in such cases, you cannot check the blood. And these are not inherited because they are sporadically occurring. But if it is coming from a parent, it means it is there in the gamete. And then in that case, it is there since the conceptus is formed. It is in the germ line. And so every tissue has it. And so you can detect it from the blood, sir.
Okay, thank you. So, so next question, Dr. Rashmi. So who are the at-risk patients in this case, and what will the screening protocol?
So, ideally, so the patients who actually get screened based on the occurrence of bilateral retinoblastoma or retinoblastoma in a child where there is a family history of the other, associated malignancies would all get automatically screened. The screening, I had also briefly mentioned this in my previous slide. It's an extensive screening and it's purely relying on the examination under anesthesia, since no imaging modality will be as sensitive as the same. Ideally, the screening is intense in the first few years of life, up until. Sorry, am I audible?
Yeah, you're audible.
So the screening is quite intense in the first few years of life. There are centers that do every month or every 2 months screening up until the age of 9 to 12 months. Followed by increasing the screening interval from increasing it from 2 months to 3 months, 3 months to 6 months, up until they are 6 to 7 years of age.
Okay, so there are some reports of retinoblastoma even in up to 12 years of age. So,
yes.
What is the time generally we go for screening? Like till what age should we screening regularly? 7 or shall we?
Yeah. So most protocols say between up until 5 to 7 years, you have to continue to screen. Then after 7 years, there are actually, some protocols who recommend screening even because by then, once they're older than 7 years, then the examinations can be done non-sedated. So to continue the 6 monthly screening for a longer period.
Okay, fine. So Dr. Shruti, one more thing. Like, what if we have a familial retinoblastoma and we don't have and the mother was or the parent was not tested for this genetic mutation. So what if we can test all the contacts, all the relatives, first and secondary relatives for this retinoblastoma with blood? Will that prevent this occurrence in the future generation?
No, so okay. So you mean that the child has a inherited retinoblastoma, and you're wondering whether the parents' extended family should be checked, is what you're asking. Of course, yes.
Exactly.
We call it as cascade testing, and we know that it may not always be that these genes and mutations may not completely be penetrant. There may be sometimes generation skipping. So a seemingly normal parent may actually be having other family members too carrying the mutation. So it's always worthwhile. Although having said that, to have a absolutely clean pedigree with a very, very notorious inherited retinoblastoma is little rare. But we should extend the benefit of carriers of the gene screening to the rest of the family members too.
Okay, thank you. So we quickly move on to this second case. So this was a 15-month-old boy, first by birth order, born of non-conscious marriage term. Period was uneventful. He presented with complaint of mild but progressive asymmetrical abdominal enlargement on the right side over past 2 months with no other complaints. There was no history of hematuria or pain abdomen. Vitals were okay and found to have aniridia, congenital glaucoma, and polar cataract for bilateral eyes, along with cryptorchidism with hypospadias, mild hypotonia, developed delay. So, as suggested was WGR syndrome. So, on CT abdomen, there was right kidney was tumor of right kidney arising from a lower pole confined to the kidney, not involving the renal pelvis and vessels. Left kidney was normal, and there was no abdominal lymphnopathy. CT chest showed no mets. And biopsy of the retroperitoneal mass was done by retroperitoneal approach, and it was found to be Wilms tumor. So, first question, Dr. Rasmi. So, how to approach this case for further management? You see, unilateral nephroblastoma of the left kidney. Hello, am I audible?
Sorry, it's a unilateral nephroblastoma, unilateral renal tumor. So so the first thing to do is to stage the disease and to assess the metastatic spread, which will involve abdominal imaging, either CT or MRI, followed by a CT chest plane. Once you confirm based on imaging, and this child also has phenotypic evidence of a Wilms tumor predisposition syndrome, so the likelihood of a non-Wilms tumor of the kidney is very unlikely. So I would actually go ahead and plan neoadjuvant chemotherapy without going for a biopsy, especially based on the imaging if you are confident that this is Wilms. In our center, we use the SIO protocol just because upfront surgery in our setting, in a medical college setting, is difficult for various reasons. So, as you have put there, SIOP does neoadjuvant chemo. I will avoid a biopsy upfront if the imaging is pretty conclusive, whereas COG goes for an upfront resection. So, being a unilateral disease, either is okay.
Okay. So, my next question, Dr. Shalini. Shalini, ma'am. So, this is unilateral renal nephroblastoma actually, and this is syndromic child. So, what would be the approach in this child, syndromic one, and has got unilateral Wilms tumor?
Okay, so because it's I hope I'm audible. Excuse me
audible.
for my poor
Audible,
quality.
Yeah, ma'am.
So because of the syndromic correlation with this Wilms tumor, even though it's unilateral, I think we should definitely try and go for nephron sparing surgery because they are prone to metachronous tumors. And of course, if it was Denny Drash or something, there was no doubt that we have to go for nephron sparing. But even here, I think we should definitely do neoadjuvant chemotherapy and then try for looking at your imaging description. It looks like it would be amenable to nephron sparing with the lower polar tumor and not involving the pelvis and all that. Of course, detailed imaging needs to be evaluated before that.
Thank you, ma'am. So, Dr. Shruti, in this case of Wilms tumor, what is the role of genetic testing in this?
So, of course, we have to, whenever we see a Wilms tumor, we go to see what are the other features, because there could be many genetic cancer predisposition syndromes that are associated in the presence of aniridia, genital problems, and Wilms tumor, especially if bilateral. We think in terms of the Wager spectrum. And in these things, the common WT1 deletion is the commonest mutation. Detecting it is very important. because Vagar is a multisystemic condition with, so again, surveillance, prognostication, risk of recurrence, prenatal, lot of other impacts. So that would be the role of genetic testing in such a child, Dr. Amit.
Yeah. So, Dr. Rashmi, so once the child has completed treatment, how do you follow up this child?
Yeah. So,
Like,
whether the imaging specifically for renal tumors is very similar to what it is for any other WT predisposing diseases like Beckwith Wiedemann or other hemihypertrophy, which would be ultrasounds, abdominal ultrasounds every 3-month interval up until they complete the 7 years of life. Specifically in Vagar, because there is also a risk of chronic kidney disease as they become older. I would continue to monitor this child with abdominal ultrasound as well as other tests for renal function for a prolonged period of time, specifically to screen for other genitourinary tumors and chronic kidney disease.
okay. Shalini ma'am, so one more thing, like, what are the conditions and what are the, like, how to follow up a child with, or when to suspect a renal tumor in a child who is born with some congenital defects? Like, what are the conditions where you should suspect, you should screen the child for renal tumors?
So definitely, if you find features of syndrome,
Ma'am, you're not audible.
Like
I think we lost your voice, ma'am. Hello.
I think Dr. Shalini had signal issue. Ma'am,
Yeah,
can you
yeah.
hear us?
No, she can't hear actually.
She might join in again. So
Yeah.
basically, yeah, we had a question. If in a pediatric surgical scenario, if we have a patient with undescended testes or some signs, when should we suspect this thing? So
Yeah.
like chromosomal anomalies we have. So there's a study. This actually was done in 2019. So they had a population-based study where they saw that if these the chromosomal anomalies, they have higher incidence of cancers. Like if we compare a normal child, if there is a chromosomal anomaly, there are 12 to 13 times more chances of a child of developing a cancer, whereas in non-chromosomal blood defect, it is like 4 to 5 times there are chances of having a cancer. I think Dr. Shalini ma'am has joined. Ma'am, you're there?
Yes, but I think my signal is very poor.
Oh,
I don't know whether you can hear me. So
We'll hear you, ma'am. So the question that Dr. Amit was asking, when should we suspect a cancer in a child who's presenting in a pediatric surgical OPD?
yeah, so definitely, I mean, one is what I was talking about. If there are features of any syndromic of, or as you were also talking, like Beckwith-Wiedemann syndrome, we would definitely screen them, and even children with Down syndrome also, there is a slightly higher incidence of having some malignancies, and genitourinary abnormalities, ambiguous genitalia. Probably we must never leave a chance to examine the abdomen, and also look for any syndromic features and family history as well. Although these are very rare, but still we should not miss them. And Weiger syndrome, like hemihypertrophy, aniridia, these are the things that we should definitely look for.
thank you, ma'am.